Back again, everybody. So thanks for hanging on and bearing with me while I was introducing the wrong speakers last time. So I will crack on. Our next speaker is Guthrie Kumar, who's a lead health economist at the Health Economics Unit. She'll be speaking about calculating the cost of end-of-life care in the UK. So over to you, Guthrie.
Great. Thanks, Sean. So hopefully everyone can see my slides. So to set the scene for this project, we were commissioned by Marie Curie to estimate the public expenditure on people in the last year of life in the UK. So we did this in partnership with the Nuffield Trust. Co-authors are just listed there. Lisa Cummins from the Health Economics Unit was leading the work on our side. So I'll just move on to the next slide. So as sort of scene setting, 650,000 adults die every year in the UK. The quality of their last year of life is greatly influenced by the care and support that they receive, particularly from publicly funded services. Of those people, roughly 1 in 6 die in poverty. And to compound that, the last year of life can be a time of financial hardship, particularly as many people might have to give up work while also facing increased costs associated with care and just being able to go about their daily activities. By 2035, it's predicted that there will be 13% more deaths. So the impact of this to public expenditure really merited investigating. So the aim of this project was to conduct, within a 4-month time period, an analysis of public expenditure in the last year of life across healthcare, social care, and social security spending to inform current spending decisions. We chose to focus on 2022 as the year of our study. Given that this was just after COVID, we felt like that was the most recent year for which we could identify more data, and felt that being after the worst of lockdown, that it would reflect activity on a general basis. We looked at the UK overall and, we built up the UK overall by looking at each of the 4 nations, so England, Scotland, Wales, and Northern Ireland. We focused only on expenditure. We didn't look at the effectiveness of different palliative care interventions or on, we didn't look at carer expenditure or impact on mental health. I'll go into more detail on the challenges and limitations, but within the time frame, there were some data and evidence gaps, and we had to rely on published and existing data from the literature. And as I mentioned, this was commissioned and funded by Marie Curie, and we undertook this in collaboration with the Nuffield Trust. So in terms of our approach to this, we undertook an evidence review, which we iterated on throughout the course of the project, and as well as engaging extensively with stakeholders in each of those sectors of healthcare, social care, and social security. So we identified, based on the literature and from stakeholders, what specific components might be in those sectors. Then we gathered the data and evidence that we could access within the time frame of the project. And then we developed a model incorporating probabilistic and deterministic sensitivity analyses to see what the impact of uncertainty, to assess the level of uncertainty in the results. In terms of the headline figures that our model generated, we estimated that 22.1 billion was spent in the UK publicly on healthcare, social care, and social security for people aged 18 or older in their final year of life, based on evidence dating to 2022. So for each of the 652,000 adults who died, that amounted to about 33.9 thousand pounds spent per person. In terms of how the public expenditure is distributed across those sectors in the UK, looking at the total UK figure, over half was spent on healthcare, so roughly 11.7 billion. with almost 5 billion spent on social care, constituting 22%, and then a quarter spent on social security payments. So just to break this down by sector, so the types of areas of healthcare spend that we identified were spending on GP practice, care delivered in GP practices, hospital care, community and hospice care. So looking at how these sort of stack up, you can see that hospital care is by far the greatest driver of the results, and in particular unplanned care in hospital, which contributed more than half of the total healthcare spend, followed by planned care in hospital. But as you can see, the hospice care, which tends to be the focus of policy discussions about end of life and palliative care, only constituted a relatively small proportion, 1.7% in outpatient community and 1.8% in inpatient. Moving on to the next slide, in terms of social care spend, we identified local authority funded care in the form of residential and nursing care and home care and other types of local authority funded care. And then the other main component was continuing healthcare. So local authority funded care, and in particular residential and nursing, contributed the most of the social care spend. In terms of social security spend, we considered expenditure on people in the last year of life of working age and those of pensionable age. So in the working age group, they were eligible for special rules at end of life for personal independence payments, attendance allowance, universal credit and carers allowance, and housing benefit. And the pensionable age, so the state pension given to people in the last year of life, is what contributed the majority of the total social security spend. So when you compare the different sectors of spending and then the largest drivers within those sectors, you can see that hospital care in total is the biggest driver, but in particular unplanned care in hospital, and healthcare contributing more than half of the total public expenditure, shows how much of a driver that is. In terms of the implications of our research, so we did identify large data gaps, particularly with community services and social care, which we couldn't get access to more granular data sets within the timeframe of the project. So that would be an area for further research. Furthermore, we didn't have the time within the scope of the project to be able to link health, social care, and social security data to deaths. So the majority of our estimates were derived from what was in the published literature. Next, another limitation was that cost data. We identified cost data that was not specific to the end of life. There is no dedicated source of unit cost data at end of life, so that is a potential area for further research. While we identified data sources from across the UK, there were gaps in specifically relating to the 4 nations. So while we could identify nation-specific cost data for England, Scotland, and Northern Ireland, we couldn't identify activity data across the board relating to those. And so where there were gaps, we had to use the nations that we had data for as proxies. And then finally, we know from the literature that people from deprived communities are more likely to experience end-of-life care within hospital. And so that would be an area for further research to go more in depth into to understand the inequalities and variation in location of care. And in terms of what the policy implications are of our work, essentially there's insufficient focus from policymakers on people at the end of life. And actually this week, a health select committee report was published that cited our work. So that shows the impact of our work and hopefully changes in the policy discussion around end of life funding. But another question we have is what is going to change the predominance of hospital care, not just at end of life, but I guess more broadly, and hopefully with the focus in the 10-year plan, that could really sort of change the dial and help focus resources in ensuring a more comfortable place of location of end of life care for people. And finally, looking into how inequalities at the end of life sort of affect the quality of care that people receive, as well as the burden on public expenditure. So yeah, I think I've reached the end of my 10 minutes, so I'll stop there.
That was brilliant, but a really, really important area to discuss. So we do have a question that's come through on the chat from Sarah Hollier. So, does hospice care cost include more than the bed-based care? So, for example, does it include visit to patients' own homes and other support services like counselling?
That is a good question. I don't have that can't recall off the top of my head just now, but I can put a link to I can put a link to the report in the chat. And yeah, sorry, we'll just have to follow up on that and get back to you.
That's fine. And well, how do I? Sorry, I've forgotten how to take that down now. There you go. Took the other way there. I suppose I just had a quick question as well, where we got a little bit of time. So, do you have a sense of how much we spend, I suppose, to comparable other countries? I know this was UK based, this specific research, but is there any sense or any literature you've seen on how we compare?
No, we didn't consider that in our analysis. So I mean, yeah, that would certainly be an area for future research, comparing like, do other countries still see that predominance of hospital-based care, particularly unplanned hospital care, or is it, what learnings can we take from other countries? But yeah, unfortunately, that wasn't something that we were able to compare in our analysis.
No, that's good. So is there plan to be any additional follow-up analysis of that kind of depending on the future funding stream? So I guess.
Yes, that'll be dependent on the future funding streams.
Brilliant. Thanks very much. Just checking if there are any more questions. But yeah, if there's no more other questions. Thanks very much for your time, Geoffrey. It was really interesting talk, and we will move on to the next talk, next speaker. So